This is a case of endovascular treatment for a ruptured large middle cerebral artery aneurysm treated through balloon-assisted coiling. Patient is a 58-year-old female, found unresponsive, intubated, brought to the field, has dense left hemiparesis and Hunt-Hess grade 4 subarachnoid hemorrhage with a left temporal intracerebral hematoma. You can see the large complex aneurysm associated with hematoma. Patients emergently taken to the angio suite, where you can see the large MC aneurysm with a proximal M1 short segment associated with a typical bifurcation. The transformed balloon is advanced. It goes into the aneurysm. We selectively catheterize the larger inferior trunk, positioning the wire distally and bringing the aneurysm all the way till we have clearly protected the entire inferior trunk. An 017 coiling microcatheter is then advanced in parallel over a wire and positioned into the aneurysm. Prior to placement of coil, the balloon is inflated to ensure protection of the inferior trunk. With the balloon inflated, now the coils can be advanced and rapidly deployed and detached. The balloon is deflated to make sure that the coil construct is stable, and then the balloon is repositioned to make sure we have adequate coverage of the neck, and then balloons reinflated as noted there. Additional coils are now positioned with the balloon still inflated. The goal being to position as many coils as possible under a single inflation. We try to avoid inflation lasting longer than 5 minutes. The balloon is now being deflated to confirm that we have adequate position, and then again reinflated for insertion of coils. Again, at each stage confirming that we have adequate complexity. As the coil mass becomes more complex, the coils become more stable, and the balloon is now deflated, yet you can see very nicely complete protection of the neck of the aneurysm because of the previously placed balloon. So the coil mass is now fairly complex and easily accommodating additional coils. Here under subtraction you can see the inflated balloon and the coils rapidly going into the large central dome section of this aneurysm. At this point you can see good filling of the superior trunk and some residual filling of the proximal neck of the aneurysm in conjunction with the superior trunk. We believe at this point the dome is well protected and the neck region is being left over. The patient was emergently taken to the operating room for decompression and clot evacuation following the coiling procedure.